dual eligible plans. So it's sort of a feast or famine when it comes to SNP enrollment. What's also incredibly frustrating is that when the MMA was authorized, it didn't mandate that the plans actually integrate with that they actually work with the states. So here you have a special needs plan that really wasn't all that special. It looked like all the other Medicare Advantage plans. Incredibly frustrating. Most didn't offer integrated products, but rather offered standalone Medicare plans. It was very hard to distinguish the first generation of SNPs in most states from other Medicare Advantage plans. MIPA, there's currently a moratorium on any new SNPs. That moratorium is going to be lifted, I think, in about a year and a half. At that point, MIPA will mandate that the SNPs have a relationship with Medicaid. Good news, we won't have any more of these Medicare-only products on the marketplace. The not-so-good news, we have lots of areas of the country where Medicaid managed care really isn't there yet. And so I don't know whether SNPs are going to matter for a lot of markets in the U.S. It's really a very selected instrument. And clearly this may seem like a plug because I'm a researcher interested in these issues, but I think we do need to think more about, there's been no evaluation here going back, are we going to see the same types of results with cost and quality as we saw with the PACE and Minnesota programs? I realize SNPs can take many different forms across many different states, so they're very different than evaluating PACE or evaluating Minnesota. But I think the SNPs, especially some of the passive enrollment that's occurred, a lot of individuals were pulled over from existing plans. So, for example, a lot of individuals who are already in All-Tex or who are in Texas Star Plus or in the Wisconsin program were passively enrolled into SNPs, into blended products. So that might provide us a nice natural experiment to see whether, we have lots of individuals that are now in these integrated, fully integrated plans. Could be a nice way to actually, think about what effect these SNPs have on costs, on quality. That's a bigger question. So the question was, doesn't that also depend on what happens to Medicare Advantage? And I think that's exactly right. That's kind of an issue beyond, we could say that with healthcare reform and a lot of things. I very much agree with that comment. Yeah. Yeah, and I think, as I was talking with one of the groups earlier today, we've seen with Medicare Advantage, it's almost CMS has, Congress has sort of slammed on the brakes and then the gas pedal and then it's been a very either-or sort of a strategy with Medicare Advantage. And I think, the SNPs in some areas have been very profitable, in other cases they haven't been, and so it'll be very, very interesting to see what happens. Although the SNP growth has been pretty consistent, but I think there's a very nice piece by the group at Mathematica sort of suggesting that to date anyway, these special needs plans haven't been very special, and they kind of look like every other Medicare Advantage product, and we need to get them to be much more blended, integrated. Marion.
I just wondered what the time frame was for that cost analysis, where they didn't come out so well. Having worked a little bit on the Wisconsin Partnership Plan, I know that initially when people come in, they raise costs because you have an unmet demand that gets met early on, and if it's long enough in time, you see a change in that pattern. But what's the time frame?
I think the follow-up was pretty tight on certainly on the PACE study. It was 6 months a year, and I think that was one of the issues that in order to really see savings, you've got to follow it out longer. I think that could be a comment about a lot of the sort of studies in this area. Something I know I'm beginning to run short on time, but let me at least work through the other two examples and make some concluding remarks. The next example is one that I'm very much involved with. I'm part of a team at Harvard that's joining with L&M Consulting in D.C. to evaluate the nursing home value-based purchasing demonstration, the NHVBP. So this recently just went out in the field. Will go out in the field, I should say, later this year. They just selected the 4 states that are going to be involved, and this is basically pay for performance for nursing homes. And they're going to pay based on 4 areas. It's still the exact payment formula hasn't been released yet, but basically they're going to pay on avoiding hospitalizations, having adequate staffing, obviously limiting deficiencies and strong performance on the MDS-based quality indicators. The key measure here are hospitalizations. Just as I suggested earlier, hospitalizations are a huge area of potential savings. The data we had from New York State certainly suggested that. Any savings within the state is going to be used, plowed back into nursing home payments for those best nursing homes along these quality dimensions in order to reward them for their good works. The key issue at CMS, of course, is budget neutrality. And so there won't be any payment if there aren't any savings from hospitalizations. And that's an important point. Each state will be on its own bottom in the demonstration. And so, you know, if one of the 4 states doesn't generate savings, there won't be any payments, even if facilities have behaved, even if particular facilities have done a lot in terms of their quality improvement and performance. In other states, if there are savings generated, there will be a payment. I think in theory that this is a very narrow solution that has a real opportunity to target the high rate of nursing home hospitalizations. There's some support for this from the 1970s, from the nursing home experiment out in San Diego. I think economists are always very excited about paying for performance. It sort of gets down to our core, right? You know, you reward good behavior and you punish bad behavior potentially. Ideally, the market would do this, but we have a lot of public payment in nursing homes, and so here's a chance to kind of try to bring a more market-based approach to paying nursing homes, potentially correcting some of this disconnect between nursing homes and hospitals. That's the good news. The drawbacks, as I just noted, it's a very narrow solution. It's not going to correct all the other, you know, HCBS in hospitals and nursing homes. Very much about nursing home hospitalizations. The other reason to be very suspicious, and I realize you're probably familiar, so I won't go through these issues in detail, but a nice review piece by my colleagues Meredith Rosenthal and Richard Frank, published a couple of years ago in Medical Care Research and Review, you know, basically concluded that P4P hasn't been all that effective in healthcare. Lots of reasons here. There's gaming, there's distortion away from unmeasured objectives, there's oftentimes rewards aren't enough to kind of move behavior. Oftentimes you're just rewarding those providers that would have been good anyway. And these kinds of rewards just widen the gulfs, the disparities potentially between the haves and the have-nots. And so, you know, thinking about why or why not nursing homes might be better or worse along these issues is I think important. And I'm a little suspicious that nursing homes it may be more difficult to show an effect relative to physicians or hospitals. But I'm really excited about P4P in nursing homes, and it should be an interesting evaluation and one that might potentially address the high rate of nursing home hospitalizations. Another you know, area that we've seen some P4P is at the state level, and there's been several states like Iowa, Kansas, Minnesota, Ohio that have tried some version of pay for performance. Not surprisingly, states don't, as I said earlier, don't sort of enjoy any of the savings from preventing hospitalizations, so they don't often use it. In fact, none of the states actually use hospitalizations as a performance indicator. Going back to my role with New York State, they were very interested in using hospitalizations as a measure with their nursing homes. They were interested in decreasing the rate of hospitalization. They just couldn't do it without some sort of federal buy-in. I think the state P4P programs are actually a really good window into the incentives here. The feds have all the incentive in the world to sort of think about hospitalizations. States have very little. The final issue, and it's very much a big picture solution, and in many ways I think the one that politically is the most difficult, but could actually most fundamentally sort of shift the incentives I've been talking about, and that's federalizing the Medicaid program. It's a pretty dramatic, obviously, proposal. You would shift all the dual eligible costs, including long-term care, to the federal government. The idea here is that the federal government has broader taxing and borrowing authority, and state revenues can often be quite volatile. So the feds presumably be more stable, although in these times, as we keep borrowing the federal government, I'm not certain I'd want the feds in my state either. This is an old idea. You know, there's articles back to the 1980s that I could find sort of suggesting this. The state governors, the National Governors Association was very bullish on this idea most recently.